الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. Inshallah, today we are going to talk about rickets in children. My name is Professor Abdulmoein Al-Agha from King Abdulaziz University Hospital, Faculty of Medicine. This presentation is available in my website aagha.kau.edu.sa. Rickets is a disease of the growing bones in which defective mineralization occurs in both bone and cartilage. So the difference between rickets in children and osteomalacia in adults, the defective mineralization in children happens in both bone and cartilage, while in adults happens in mature bone only without cartilage. And because cartilage composed of epiphyseal growth plates, so when defective mineralization happens in children is associated with defective mineralization of cartilage and impaired growth, is associated with growth retardation, rickets, as well as skeletal deformities. As I mentioned, osteomalacia is a disorder of the mature bone in which mineralization of the new osteoid bone is inadequate or delayed. Skeletal muscles have a vitamin D receptor and may require vitamin D for maximum function. Vitamin D deficiency causes, in addition to rickets, causes muscle weakness, muscle spasm, hypotonia. All are manifestation of vitamin D deficiency. Brain, parathyroid gland, breast, colon tissues, as well as immune cells have vitamin D receptor. That means that all these tissues, not only the bones, not only the muscles, brain as well, parathyroid gland, breast, colon, immune system needs vitamin D. So vitamin D is an important vitamin and as well an important hormone for various tissues of the body. Recent data documenting that high prevalence of vitamin D deficiency in Saudi Arabia, as well as in countries where the weather is hot, so people avoiding exposure to the sun, Saudi Arabia and the Gulf region. So because we have a hot temperature and we don't expose to sun, we have to increase dietary vitamin D intake. Epidemiological studies and new information on the role of vitamin D in the preventing autoimmune disease, preventing cardiovascular disease, and preventing cancer. And this is very fascinating studies indicating the role of vitamin D not only for the bone, strength of the bone, preventing osteomalacia, preventing rickets, not only for muscles, muscle spasm, muscle pain, also for prevention of major and serious diseases, for example, prevention of autoimmune diseases, including type 1 diabetes, prevention of cardiovascular premature events, preventing some certain cancer like colon cancer, breast cancer. Very important for all of us, for all people hearing me, to be sure that their vitamin D level in the blood is normal, and if it is deficient, to replace the deficiency by dietary vitamin D intake. Prospective and retrospective epidemiological studies all indicate that level of 25 hydroxy vitamin D below 20 nanogram per ml are associated with 30 to 50% increased risk of colon cancer, prostate cancer, breast cancer, along with high mortality from these cancers. So if these cancers la samahallah happen, the mortality rate will be higher in those with vitamin D deficiency comparing with those with normal vitamin D status. Let's see how the metabolism of vitamin D happens in our body. First of all people, the skin of all people contains 7-dehydrocholesterol. So vitamin D precursor, or the raw material for vitamin D called 7-dehydrocholesterol, is available by Allah Azza Jal, is given by Allah Azza Jal to all people in their dermis. What we need only just sun exposure. If somebody exposed to the sun, for white people, they have to be exposed 15 to 20 minutes per day. For those with dark skin, they have to expose 20 to 30 minutes per day. With sun exposure, 7-dehydrocholesterol will be converted into vitamin D. In countries like Saudi Arabia, where people, most of the people does not or don't expose to sun exposure, they have to have enough vitamin from the diet, whether it's a vitamin D supplements or vitamin D fortified products, dairy products, they have to take it from diet. Vitamin D, whether from sun exposure or from diet, will be converted in the liver into 25-hydroxy vitamin D through the enzyme called 25-hydroxylase enzyme. Then in the kidney, 25-hydroxy vitamin D will be converted into 1,25-dihydroxy vitamin D. This is the active form of vitamin D, 1,25-dihydroxy vitamin D. The active form, in order to have the action on the target tissue, should bind to vitamin D receptor. So if we have a normal vitamin D metabolites, 125-dihydroxy vitamin D, but the receptor is not active, is not functioning, we'll have also rickets. So we need to have a receptor sensitive to the 125, the active form of vitamin D, 125-dihydroxy vitamin D, in order to have the biological effects of vitamin D. I remind you again, vitamin D receptor present in the colon, in the intestine, in the kidney, in the bone, in parathyroid gland, in hair follicles. In hair follicle, very important vitamin D receptor hair follicle. That's why those with vitamin D deficiency, they complain of hair falling of their hairs and alopecia because of vitamin D deficiency. The sources of vitamin D, the natural source from Allah by sunlight, as well as from the fortified milk products, from the cod liver oil, and from the egg yolk. Types of rickets, either the commonest type is hypocalcemic rickets, but also we could see rarely, not as common as hypocalcemic ricket, we could see hypophosphatemic ricket, and in certain diseases we have a combination of both hypocalcemic ricket and hypophosphatemic ricket in the same person. Let's come to first the commonest type, which is hypocalcemic ricket, and one of the major feature of hypocalcemic ricket, or one of the major pathognomic feature of hypocalcemic ricket, is high parathyroid hormone. So whenever we have low calcium, parathyroid hormone will be elevated, and this elevation is a physiological elevation, what is called secondary hyperparathyroidism. So the disease is not from parathyroid, it is a physiological response from parathyroid due to low calcium. Any cause of vitamin D deficiency will lead to hypocalcemia, and hypocalcemia will lead to elevated parathyroid. Major causes of vitamin D deficiency: number one, decreased sun exposure, and this is the commonest. This is what happened in Saudi Arabia, as well as most of the hot countries. Nobody exposed to the sun. That's why most of Saudi Arabia population is deficient from vitamin D. Dietary deficient intake, and also this is another problem in most of the people. They don't drink milk or fortified dairy products, and their diet is totally unhealthy. That's why if they didn't expose to sun and didn't take dietary sufficient intake of vitamin D, they will have a vitamin D deficiency. Malabsorption is another cause, but not as common as poor sun exposure and poor dietary intake of milk, but still one of the good reasons of hypocalcemic vitamin D deficiency: malabsorption disease, especially celiac disease, cystic fibrosis, chronic diarrhea, whatever gastrointestinal problem. Chronic gastrointestinal problem lead to deficiency of vitamin D absorption. Chronic liver diseases, because as we mentioned, that will affect the conversion of cholecalciferol to calcidiol. Calcidiol is 25 hydroxy vitamin D. Anticonvulsant, chronic anticonvulsant drug usage is another important factor of vitamin D deficiency. That's why we encourage our neurologists, pediatric neurologists, whenever they face a child on anticonvulsant, to give him at least the prophylactic dose of vitamin D in order to prevent vitamin D deficiency. As I mentioned, celiac disease is an important factor of vitamin D deficiency, cystic fibrosis, hepatobiliary diseases like biliary atresia, cirrhosis, neonatal hepatitis, drugs like anticonvulsant phenytoin, phenobarbital, and lastly, but not the least, is dietary bad dietary habits, especially excess of phytate. Phytate in diet usually impair absorption of calcium and iron, and the classical example of phytate is shabati, khubz shabati. Shabati bread has a high phytate level, and high phytate level will impair calcium and iron absorption. Nutritional rickets is the commonest cause of hypocalcemic ricket. It is globally the commonest cause all over the world, and infants fed exclusively with the mother's milk can develop nutritional rickets because of low content of vitamin D in the breast milk. That's why we encourage the mothers during lactation and during pregnancy to have vitamin D supplement. If the mother is deficient, she should take therapeutic dose of vitamin D. If the mother is not deficient with vitamin D, she should take prophylactic dose of vitamin D, because her baby needs extra supplement from her breast milk, as naturally breast milk has a low vitamin D status. In premature infants, insufficient amount of both calcium and phosphorus may cause nutrition rickets. In prematures, they have a risk of hypophosphatemic ricket as well as hypocalcemic rickets. Infants with low or no sun exposure may develop rickets, particularly if they have dark skin, because of decreased vitamin D production by the skin after exposure to ultraviolet light. In Saudi Arabia, as mentioned before, we have commonly vitamin D deficiency in the community, and majority of the reason because kept indoor. Most of us, we are indoor when the sun is around, and we go outside the door when the sun is no longer in the night. We go outside the door. And covering the body, dark skin is another risk factor. And for the mothers, lactating mothers, if they have low vitamin D status in their body, or if they are giving exclusive breastfeeding. What is the meaning of exclusive breastfeeding? A lot of mothers, they continue to breastfeed their children for 2 years exclusively. There is no problem of breastfeeding for 2 years. That is in Quran, no problem. But the problem if they're giving exclusively breastfeeding. After 6 months of life, the baby should have breast milk in addition to other dietary supplement, other dietary food. Age of weaning start from age of 6 months, not to continue to give him breast milk alone for the 2 years duration. Should have, in addition to breast milk, should have other dietary food supplement. The major 2 peaks of the rickets in Saudi Arabia during the first 2 years of life and during pubertal stage. Chronic renal failure, what is called renal osteodystrophy, is another important cause of rickets. Renal tubular acidosis, whether it's proximal, generalized Fanconi type, have a combination of hypocalcemic and hypophosphatemic ricket, while isolated hypophosphatemic ricket, the hereditary one, has only hypophosphatemia, or rather than combination of hypocalcemia and hypophosphatemia. Hereditary rickets, we have type 1 vitamin D dependent rickets, autosomal recessive disease with the lack of 1-alpha hydroxylase enzyme. So in this case, it's similar to chronic renal failure, but the renal function is normal in vitamin D dependent type 1, while vitamin D dependent type 2 is a misnomer. The name is wrong. This is a resistant, receptor resistance, so should be called vitamin D receptor resistance rather than vitamin D dependent type 2. Chronic liver diseases is another important cause of rickets in children. Renal isodystrophy due to lack of 1-alpha hydroxylase enzyme. Fanconi syndrome is a classical example of proximal renal tubular acidosis of the kidney, in which glucose, amino acid, uric acid, phosphate, and bicarbonate are passed into the urine instead of being reabsorbed, resulting in combination form of rickets, hypocalcemia, and hypophosphatemic rickets. This is a child with jaundice, as you can see, biliary disease, hepatobiliary disease, and hepatic rickets. Malabsorption is very important cause of vitamin D deficiency, and in malabsorption not only vitamin D is low, all the fat soluble vitamins will be low, vitamin A will be low, vitamin D will be low, vitamin E will be low, and vitamin K. Congenital rickets. What is congenital rickets? Congenital rickets that any rickets happen in first 6 months of life because of lack of maternal vitamin D. During pregnancy, if the mother has vitamin D deficiency or she did not have enough supplement of vitamin D, her baby will have deficiency of vitamin D during gestation and born with low vitamin D. When the baby born with low vitamin D, that is congenital vitamin D deficiency. Vitamin D deficiency happened intrauterine life and manifested after birth. Usually the manifestation after birth with low calcium, and secondary to low calcium, the child might come to the emergency room with convulsion, with carboplacental spasm, and the reason behind that is low calcium. And why low calcium? Because low vitamin D. And why low vitamin D in the baby? Because of low vitamin D in the mother during pregnancy. That's why we encourage all the mothers during gestation and as well as during lactation to have enough supplement of vitamin D, and always they check their vitamin D status. Hereditary rickets, we have hypophosphatemic ricket and we have vitamin D dependent rickets. The vitamin D dependent rickets, as I mentioned before, type 1 autosomal recessive disease because of lack of 1-alpha hydroxylase enzyme. 1-alpha hydroxylase enzyme is essential in the conversion of 25-hydroxy vitamin D into the active form calcitriol 1,25-dihydroxy vitamin D. So whenever the child has lack of 1-alpha hydroxylase enzyme, they will have low calcitriol, and the low calcitriol will lead to rickets lifelong, and then the child will be lifelong dependent on the active form of vitamin D therapy. While in type 2, which is autosomal recessive disorder as well, but the problem is not from the enzyme. The enzyme is normal, but the problem from the receptor. Calcitriol receptor is deficient and resistant to calcitriol. So this is a real vitamin D resistant ricket. The real name for this one should be vitamin D resistant ricket rather than vitamin D dependent type 2. It is common in Arabs. Why common in Arabs? Because high rate of consanguinity, and this is autosomal recessive disease. As well, the child, this type, the child characteristically to be have hair loss or alopecia. Why hair loss? As mentioned before, hair follicles composed of vitamin D. So when the child has a vitamin D receptor resistance, vitamin D receptor in the hair follicle will not benefit from the vitamin D, and there will be hair loss. Usually this type is severe form, and usually they are not responsive to vitamin D therapy. They need long time, lifelong high dose of oral calcium and oral phosphate. Vitamin D dependent rickets mentioned about type 1 and type 2. And regarding this is a child with type 2 vitamin D dependent rickets. As you can see, alopecia capitis. Why alopecia capitis? Because of vitamin D receptor resistance. As well as you can see, there is no eyelashes, eyebrows, all deficient. So alopecia, almost alopecia totalis, or alopecia universalis, and vitamin D dependent type 2 between two bracket vitamin D resistant ricket. If you can see, there are scars here, scars of central line insertion. Why central line insertion here? This is all the scar, and this is another scar. This child has been admitted to my unit with vitamin D resistant ricket. The main therapy for this child initially was through central line insertion, large doses of calcium, intravenous calcium, as well as large doses of intravenous phosphate. And when the patient has a complete resolution of ricket clinically and biochemically as well radiologically, then shifted to high doses, lifelong high doses of oral calcium as well as oral phosphate. Hypophosphatemic ricket is less common than hypocalcemic ricket, but we encourage pediatricians should be aware of its occurrence. And usually this ricket characterized by rickets associated with hypophosphatemia as well as skeletal deformities. Causes of hypophosphatemic ricket, but very important before we go to causes, in hypophosphatemic ricket, one of pathognomic feature that parathyroid hormone is normal, opposite to hypocalcemic ricket. Hypocalcemic ricket always have high parathyroid hormone, while in hypophosphatemic ricket, usually most of the time, all of the time, parathyroid hormone is normal, because phosphate has nothing to do with parathyroid hormone, is not a stimulus of parathyroid hormone. What are the causes? Number one, nutritional phosphate deficiency. Number two, very important, prematurity. Prematurity is one of the common causes of hypophosphatemia. Number three, decrease intestinal absorption of phosphate, especially those who are using antacid frequently. Those with reflux, gastroesophageal reflux, always they have a heartburn. They're using antacid. Antacid contain aluminum hydroxide. Aluminum hydroxide usually impair the absorption of phosphate. Renal tubular acidosis, whether it's a proximal type or distal type, is associated with hypophosphatemic ricket. Tumor-induced osteomalacia between two bracket oncogenic osteomalacia. Why in tumor, especially bone tumors, is associated with hypophosphatemic ricket? Because the release of something called a peptide called parathyroid hormone related peptide. So there will be a peptide similar in the structure to parathyroid hormone, and this release in malignancies, especially bone malignancy. So when parathyroid hormone related peptide, not the parathyroid hormone itself, it is a related peptide released, it works or function like parathyroid hormone. It increases the calcium, will have hypercalcemia, and that's why in malignancy there is something called hypercalcemia malignancy, as well as hypophosphatemic rickets. So the child will have, anyone with bone malignancy or with tumor-induced hypophosphatemia, they will have high calcium and low phosphate due to high level of parathyroid hormone related peptide. And lastly but not least, common cause of hypophosphatemic ricket is hereditary hypophosphatemic ricket. McCune-Albright syndrome is another cause of hypophosphatemic ricket. Hereditary hypophosphatemic ricket usually inherited as sex-linked dominant ricket or occasionally autosomal dominant. The commonest sort of inheritance in hypophosphatemic ricket is sex-linked dominant, while in occasion or few cases autosomal dominant. Males affected more than females because it is sex-linked dominant. It is the commonest inherited form of rickets, more common than vitamin D dependent ricket. The prevalence is 1 to 25,000 patients. Phosphate will be low. Calcium should be normal because this is isolated hypophosphatemic rickets. So by definition, phosphate is low and calcium is normal. And vitamin D, the active form of vitamin D, 125 dihydroxyvitamin D, will be low because phosphate is a major stimulus for 1-alpha hydroxylase. Usually in this form, the ricket is severe and the child is having short stature with early presentation. Oncogenic histomalacia mentioned before because of release of parathyroid hormone related peptide. Congenital rickets because of lack of maternal vitamin D. Clinical features of ricket. In hypocalcemic ricket, the majority of children with hypocalcemic rickets come with manifestation of ricket as well as manifestation of hypocalcemia. What are the commonest manifestation of hypocalcemia? Seizure, convulsion, apnea, and tetany. But some children comes with delayed gross motor milestones, hypotonia. Some children comes with enlargement of the wrist, comes with bong of the long bones. In the examination, we find the rachitic rosary, Harrison sulcus, late closure of anterior fontanelle, parietal and frontal bossing, craniotabes, delayed in tooth eruption, enamel hypoplasia, decreased bone mineral density, myopathy, and they are at risk of infection because we mentioned that vitamin D is important in the immune system, especially in process of phagocytosis. And this slide summarizes the various presentation, clinical manifestation of rickets. Common to have bowing of the legs, occasionally to have knock knee. Bowing of the legs called geno-vara, knock knees called geno-valgus. So the commonest clinical manifestation is bowing, but we could also see knock knees in rickets. As I mentioned, there will be craniotabes, delayed closure of anterior fontanelle, frontal and parietal bossing, delayed eruption of teeth, enamel hypoplasia. In this slide, you could see widening of the wrist. This is a good example of widening of the wrist. Always look for that sign in any patient with ricket. Here you could see very easily rachitic rosary, enlargement of costochondral junction cartilages. Very, very good to see. And here what is a slide shows, it is pigeon chest or pectus carinatum, and here is the Harrison sulcus. Harrison sulcus is another important manifestation of rickets. Biochemically, if we have hypocalcemic ricket, biochemically calcium initially will be low, and then parathyroid hormone will be released, secreted with secondary hyperparathyroidism. Then the second stage will be normal calcium. So initially low calcium, then becomes normal calcium. Phosphate in hypocalcemic ricket should be normal initially, but when hyperparathyroidism happens, there will be low phosphate level. Parathyroid hormone is always high in hypocalcemic ricket. It is called secondary compensation to compensate for low calcium. And alkaline phosphatase will be high, urinary calcium will be low, 25 hydroxyvitamin D will be low, and parathyroid hormone will be high in hypocalcemic ricket. While in hypophosphatemic ricket, the serum phosphate is low, always low. There is no compensation by parathyroid hormone, so always low without treatment, of course. The calcium always normal, parathyroid hormone always normal, but alkaline phosphatase is high, and level of 125 dihydroxyvitamin D will be low because, as we mentioned, phosphate is a major stimulus for 1-alpha hydroxylase enzyme activity. Radiological features of rickets: number 1 is generalized osteopenia. Number 2, widening of epiphyseal growth plate. Number 3, fraying of metaphysis of the long bones, bowing of legs, pseudofractures. Pseudofractures, the other name of pseudofractures is loser zone, or we could have a complete real fracture from chronic rickets. And in severe cases, ignored cases, untreated cases, there will be the secondary hyperparathyroidism will be converted or changed into tertiary hyperparathyroidism, and with tertiary hyperparathyroidism we find what is called osteitis fibrosa cystica. And this slide showing the cupping, this is cupping of the bone, fraying of the bone, osteopenia, displaying, which is the distance between carpal bones and the end of the radius is high, the distance is increased, that is called displaying. And this child starts to have wide zone, that is called zone of calcification. This is a partially treated ricket. We still have fraying and cupping and widening, but if you can see, there is a white line here that is called zone of calcification. This is loser zone or green stick fracture because of rickets. Prevention is very important for any child or adult living in Saudi Arabia or living in countries with poor sun exposure. And the prevention starts from early life. So in prematures or in the twins, we should give 800 vitamin D per day. The dose of vitamin D is 800 units per day. In full term, 400 units per day up to age of 1 year. If we have vitamin D deficiency, we should give a replacement therapy. The dose in adult, 50,000 units per week in adult and children, older children, 50,000 units per week, or 2,000 to 7,000 units per day, international units per day, 2,000 to 7,000 international units per day for at least 2 to 3 months. And after that, when the vitamin D becomes normal, then shift it to prophylactic dose. Prophylactic dose of vitamin D is 50,000 units per month. Again, for the therapeutic dose of vitamin D, 50,000 units of vitamin D per week. When vitamin D becomes normal, 2 to 3 months after therapy, 50,000 units per month. In the first 2 weeks of management, of ricket management, we should combine it with calcium. Calcium in the first 2 weeks. Why? To prevent what is called hungry bone phenomena. Treatment of chronic renal failure, treatment of hypoparathyroidism, treatment of vitamin D dependent type 1, treatment of hypophosphatemic ricket. The vitamin D should be in the form of 1-alpha hydroxyvitamin D, should not be the classical or vitamin D2 or vitamin D3, should have 1-alpha. And children with chronic liver failure should receive the most active form, which is 125 dihydroxyvitamin D. By this, I end up my presentation. Thank you very much for your listening.